Kia ora koutou. My name's Jen. My pronouns are she and her. I'm 2AC at Utopia and Rainbow People Health and Wellbeing Advisor at Pegasus Health. Thank you for joining our chat about the Canterbury Waitaha transgender healthcare approach. With me today is Dr. Rebecca Nichols, our clinical lead for transgender health in Canterbury, and Dr. Samantha Chow, a CDHB psychiatrist. Next slide, thanks. So we really started this mahi about 4 years ago, and where we were is similar to probably what was the case across a lot of the country, just a really inconsistent experience, your classic postcode lottery. We had one pathway for gender-affirming care, but there was no agreement on that process. So people's experiences really varied depending on who they were referred to, when, and by who. We had really limited services, and there was no trust between the system and the community, kind of going both ways. So there'd been a couple of opportunities for community consultation, but not much had happened, and there really was a lack of trust. So at that time, we had this opportunity come up through the HQSC Awatea co-design project. Esther Valero, another member of our team, put her hand up to sign us up for that. And our project was co-designing gender-affirming care in Canterbury, really building a new system from the ground up with community input right from the beginning. I'll hand over to Dr. Rebecca Nichols to talk about what we've done.
Kia ora koutou, everyone. So this is our system. It's pretty complex. What became evident pretty quickly is there's a lot of players that you've got to get lined up to make sure that the system works, functions really well. So it was a lot of people to make connections with and to continue to maintain relationships with as well. Thanks, next slide. We had some really great wins. We got a number of new services in place, lots of different surgeries, general practitioners providing an informed consent model, fertility services, a transgender package of care, which helps with therapy or treatment for mental health, puberty blockers, and then a number of other services like binding libraries. But really, really usefully, a whole lot of new connections that didn't exist before between peer support services, GPs, psychologists, DHB, and again, maintaining those. And then 6 health pathways, like looking after a range of ages and lots of different sorts of care required in gender-affirming journey. And then an amazing suite of information on health info for patients and families. And as I said before, have moved to informed consent model, and which is provided in primary care. We identified a number of champions. So we have a community champion, a hospital champion, and a mental health champion, meaning that these people can wander in and unstick anything that goes a bit wrong at any stage. And we also developed a DHB email, which is really useful for people just to get hold of one of us at any stage to ask the tricky questions that don't fit into a pathway. We also had to make a multi-location model work because we're never going to get a building and a receptionist and a social worker and things sitting in one place. So we're all there, but we're all spread out, and you've got to maintain pretty good relationships to keep that working. We've got some PHO funding around the general practice budgets and some other additional things like their long-term contraception. And we also lobbied the Ministry of Health for GP referrals for gender reconstruction surgery. Next slide, please. Yeah, definitely some challenges along the way. The challenges are that in the end, reasonably small population here in Waitaha, and that mean, small numbers in small teams, and this does mean if one person doesn't want to provide care, wants to do something else, or gets unwell, that team pretty much falls over, and so you have to work pretty hard continuing to sort of build some capacity. We definitely met with some conservatism and transphobia along the way, and again, having networks and being able to support each other is really important. Mental health continues to be a challenge while things remain underfunded, and so we've developed pretty significant public system wait lists and wait lists for private care as well. Ongoing problem with lack of data, but we find counting ourselves incredibly useful to take places to improve around some data for care. Also a lack of resources at times. We've got a gap for 18 to 19-year-olds. We've definitely got some budget problems that keep coming up with surgery and mental health underfunding, and we haven't yet been resourced properly in primary care to provide this care. But, some really cool tips that we learned along the way about maintaining flexibility in the system. Absolutely 100% begin and end with the community. And also, especially with clinicians, get really small, safe groups together. So the smaller the group, the more chance that people will provide care. So definitely started with maybe just even 1 or 2 clinicians in a department, and then built outwards from there, just so that people can really voice what they need. Over to you, Samantha.
All right, thank you. Kia ora, everybody. My name is Samantha. So I'm a psychiatrist. I work with the CDHB. So I'm going to talk to you about, the relationship between gender diverse patients with CDHB. So historically speaking, there isn't a formal pathway for people with gender dysphoria to be seen by the CDHB, because not many people actually recognize that as a mental disorder, and hence there's no professional development. Back then, it was still considered a very rare occurrence. But our site consult liaison service at the hospital has somewhat reluctantly agreed to do one-off gender assessments as a favor, mostly for endocrinology, for the past 20 years. But the number of cases began to rise in the last 5 to 10 years, and they were also becoming increasingly complex. And because there was no formal pathway, there was also no referral guidelines, so they were getting referrals from everywhere. And in the end, site consult became overwhelmed, and the wait times ballooned to 18 months. This is when Rebecca and I stepped in, and we formed a gender clinic of sorts and tidy up the referral process, and we were able to bring the wait times down to 3.5 months. So happy days. Right, so some of the challenges I find, I conducted the clinic once a week out of Christchurch Hospital. It was a 4-hour affair, 2-hour assessment with 2-hour admin, so basically 0.1 of my FTE. But it also means that pulled me away from my usual community mental health team that put a strain on my team, and they weren't really super happy about that. So 90% of the cases I saw were really straightforward, but 10% were very complex. I've seen patients with schizophrenia, with residual psychosis, severe intellectual disability or autism, DID with multiple personalities, with or without trauma. And because I was operating as a lone wolf, it was hard to get any kind of MDT support. And there was, of course, some added complexity from the corrections side of things at prison people. Unfortunately, forensics don't have any resources to devote, so it fell onto me. And because of the lack of resources, I had to triage, and that led to very unequal access to care, which of course caused problems in terms of human rights issues, and an HDC complaint made against me. Eventually, I burnt out, and I was forced to shut down the clinic after just 1 year. But I found the work very rewarding nonetheless. So in the end, there were some questions left unanswered. For example, my colleagues are still debating the merits of the gatekeeping versus the informed consent model. Now, to be clear, the informed consent model is a form of gatekeeping as well, but just a lot less gatekeeping. The trick is finding the right balance between how much you're going to gatekeep and that involves coming up with a good referral system and guidelines. And we're still tweaking the model to find out what works. And of course, in my circle, there's a lot of debate on whether or not gender dysphoria is indeed a mental illness. Because if it is, then of course, all of us need to upskill. But if it's not, then we're essentially excluded from the budget. There's no mental health needed. And again, I feel like, transgender and non-binary healthcare is largely a social issue, and people have been asking questions, should we start teaching social sciences at medical school? And of course, what is the doctor's responsibilities in terms of, advocating for our patients and fellow community members? And that's my take.